Okay, that is what we believe, that this is like it's with this SPM. I would use SPM. Okay, that is for a short for this repeating the name. It could be used, that is to restore function of leukocytes, which might have been suppressed during the disease process, or simply facilitate and enhance capacity to respond to that. The disease what I'm interested to study, that this is sepsis, and it is sepsis that is like it's best defined, that is like as a completely dysregulated immune response, followed by an immunosuppressive state, and this is what portends poor prognosis for the patient. So that it's part of the equation that this is the suppressed function of neutrophils. So that the promise is there, that is like it's, if we can restore their normal function, like phagocytosis, production of mediators which dampen the inflammatory response, that we might have a therapeutic opportunity for countering the disease. That this would be very difficult to do in a few seconds. Okay, that as I said, that is like it's in a sepsis, that this is a dysregulated immune function that is involve innate immunity, adaptive immunity. So that is it's if one want to put one of the substantial problem in this disease, that is neutrophil granulocytes, they would not go where they should go, like a site of the infection, for example, or a site of a tissue damage, but instead, for whatever reason, they are choosing to go to places like the lung. Usually, the lung is the first to fail in these patients, or a kidney, when they have no business to do. So that is what we believe, that with these SPMs, we can redirect to them, that is to the site when they should go, and not the site when they should not go, because that is when they accumulate in those organs, that is like it's what happening, they become activated, trapped there, and it is inducing tissue damage. So it is, and this is really what portending the poor prognosis. So it is what we think, that this is like is with these SPMs, that is we can restore neutrophil function, redirect them to their normal lifespan, facilitate their removal by macrophages, and that this complexity, that is assuring that reprogramming macrophages, reprogramming to promote resolution of inflammation. Of course, many other cell types is involved in that one. That is recent data also show that this is like is this SPMs, like is the 15 epi-lipoxin A4 and the 17 epi-RVD1, that is affecting regulatory T cells, for example. So that is the implications are way larger than what we think from sepsis. Okay, so that infectious diseases in general, it's very difficult to tell, because that is depending, that is whether you're looking for a viral infection, that is like is different type of SPMs, like RVD2, for example, are important, or has been shown to have some beneficial effect in experimental models. In terms of infections, that is we think that this is like is if we can enhance the function of neutrophils, and with that one modulating the reprogramming of macrophages to promoting clearance of infection, that this is we think it's one point. That is the other point is that its previous data showed that by using these SPMs, you can reduce the requirement for antibiotics. That this is obviously that is it would work for that. That is like it's preventing antibiotic resistance, if possible. But the third point, which I would like to raise, and that in septic patients, that is what we see them, that is around 1/3 of them, maybe a little bit higher percentage, they do not have any bacteria detectable in their blood or in their tissues when they are admitted to the intensive care unit. So that under such condition, that we have to look for other mediators which maintain that kind of a dysregulated immune function. And it is, I think that this might be a very nice opportunity to using these SPMs to restore an impaired function of these cells, in a hope that we can prevent secondary infection, which is usually, it's a very poor prognosis if patients getting the secondary infection, or simple by restoring phagocytic capacity of neutrophils and possible macrophages, that this is a process which also needed for repairing damaged tissues. We have different lines of research ongoing. That is, we try to identify factors which can dysregulate innate immunity even in the absence of bacteria. So we are looking for bacterial constituents, for example, bacterial DNA, which resist degradation by DNase 1, so that it can persist much longer time in the blood or tissues, or factors which I release from injured tissue, from the mitochondria, which mitochondria you should consider as an ancient bacteria. So the mitochondrial DNA share the structure of bacterial DNA, which can be released following any type of tissue damage, or formulated peptides, this is also an ancient bacterial peptide, which we have. So that upon tissue damage, mitochondria would be damaged, and that this constituents released into the circulation, and it is this may evoke an immune response and causing a dysregulation of the immune system, suppressing immune responses. So that we try to identify this one, that this is looking for patients. That is the other point. What we try to do, that is like we try to look for patient samples, that's from septic patients, and it is to look at that is whether they show decreased phagocytosis or not, because that is not all of them showing. So it is try to understand who has developed decreased phagocytosis and who did not. And it is the promise here, that one that is like is those who developed suppressed phagocytosis, that is using this SPMs, and it is I would refer to them because we were focusing on the SPM which were acting through the ALX FBR2 receptors. So it is which one of that one, it does not seem to matter. It's the receptor seems to matter, that is to try to restore the functionality of those cells. And it is I would like to stress one point here, that this is like is phagocytosis, and this is phagocytic capacity of neutrophils and macrophages, that this is a critical component which assure that we can repair damaged tissue. Does not matter what caused the repair, but without phagocytosis there is no efficient repair. So that innate immunity, that this is what people used to say, that what we born with that one. So that is innate immunity, that is essentially responsible for the inflammatory response. But inflammation, that this is a protective response. It's without inflammation, you can guess it how long we can survive, but I think a day would be too long. We are living in a bacterial world, okay? Bacterial viral world. So that is, we need inflammation because that this is protecting us. It's a problem is that one that when we're talking about inflammation, it's everybody knows that it's like it's the diseases. Those are inflammatory diseases, and we recognize them more and more. That is like it's atherosclerosis. That this is an inflammatory disease. Arthritis. Okay, so that is because that is inflammation driving. So that is the question of that one. That is like it's when the protective function of the innate immune system that is turned against, and it is prolonging the inflammatory response, or other words, we cannot shut it down, the inflammatory response. That inflammation going at a very low level, but for a very, very long time, and is causing tissue damage. So this is why it is associated with many, many diseases. I think it's, if you scratch, essentially all diseases have an inflammatory component. That is adaptive immunity, that this is a specialized form of the immune system, that this is when the response develops upon contact with pathogens and agent, and it is like it's generating memory cells for that one, and it is like it's adaptive immunity that activate lymphocytes, different lymphocytes, that is like T cells, B cells to producing antibodies, and that this is acting in concert with innate immunity to assure homeostasis or maintaining of homeostasis. Okay, so that one is an intriguing question. That is when we came upon that. It's interference, that this is part of the adaptive immunity, because that is interferon produced in response to viral infection most of the time. It is what we found, that during resolution of inflammation, then macrophages, phagocytosing, apoptotic neutrophils, that a subset of these macrophages, that is stop phagocytosing, so that they refuse to eat more, they became satiated, they are reprogrammed, and they do express interferon beta. So that they release interferon beta, which is acting back on neutrophils, promoting the neutrophil death, promoting the uptake of apoptotic neutrophils by the macrophages, but at the same time, that is, they are promoting the production of pro-resolving lipid mediators, Lipoxin A4, resolving D1, for example. And that these are acting in concert with interferon beta on the cells, and that these SPMs are responsible to restoring the phagocytic capacity of neutrophils. So that we have a kind of a feed-forward circle. When neutrophils need to die, to being phagocytosed by macrophages, the macrophages would produce interferon beta, which is acting back to promoting neutrophil death, but cannot promote phagocytosis. So that is, to restoring phagocytosis-induced death, you need SPMs. And it is that coming, that is like it's interferon beta, that is induces the formation of this SPMs by neutrophils, but most likely that is predominantly that is the macrophages which produce that one, and it is forming a feed-forward loop involving neutrophils, macrophages, that the bacteria or the tissue to be cleared, and to assure efficient clearing of those agents and removing. That is the intriguing thing of interferon beta. That is interferon beta that was clinically appeared to be very efficient of protecting against lung injury, like the acute respiratory distress syndrome in the original SARS, also in COVID-19. And that is what we found, that this is like it's just working beautifully in bacterial infection. And it is probably that this is like it's if the lung injury is provoked by bacterial constituent or mitochondrial components, then again interferon beta it seems to be a quite intriguing choice to try to counter these actions. Okay, that is the number one challenge, that is to change people perception. Okay, the clinical practice is that is when clinicians suspect infection, they prescribe antibiotics. Is the symptoms, it may indicate that there is an infection there. Okay, But as I said, that is like this tissue damage, and that like acute respiratory distress syndrome could develop in the absence of bacteria. So that is why I give antibiotics. So that is with the SPMs, that is like it's the problem that is these are lipids. Lipids are usually short-lived. So that is in a therapy that this is like it's when you assure that this is like it's to counter, even that is like this to reduce antibiotic requirement or just promote the natural defense mechanism. Okay? That you would need a prolonged action of a drug. So that is if they have a short half-life, that make a challenge. Of course, that is like it's if you develop structural analogs to this molecule, which a longer lifespan, that is one of the issue, one of the obvious solution. The other thing is that is like you can look at the receptor, and it is the receptor that is it's what we work with. That is like is the lipoxin and the resolvin D1. That these are acting on one well-defined receptor. That this is the ALX-FPR2. So that is the idea would be that is like it's if you can develop an agonist that is acting on this receptor independent of these lipids, okay, that is using the lipid binding pocket of the receptor. I should tell that one that this is a receptor that is no other receptor we have in a body, because we have more than 2,000 of structurally independent ligands for this receptor, which can trigger inflammatory processes, but also switch on the resolution mechanism. So that is, you have a receptor with that function. If we can find, okay, whether it's a structural analog or an other small molecule but agonist, okay, that for the receptor, that is, we can activate resolution programs. And I think that this is a promise of what we call that is the resolution pharmacology, that is to promote the body own defenses, own defense mechanism, which might have been impaired, suppressed, misdirected, dysregulated, to put back in a process. That is when we can assure that is the protective function of the inflammatory response. And it is pleased that is like it's I would like to emphasize, I was talking about neutrophils, and most people would associate neutrophils with tissue damage. Yes, that's correct. But without neutrophils, we cannot repair tissues. So that is, neutrophils itself had a healing power. So that with the promise of these pro-resolving mediators, whether these are lipids or some small molecule agonist, okay, that is the promise is that one we can restore the healing power of the body. So that this is conceptually different. And that is when you see that is the challenges, is try to explain to people who were living with that one, and that is like it's all therapies, we are blocking things. And it is not that this is a conceptual change, that is no, we are promoting something which we already had it, but want to restore the capacity. So that is, we want to go back to the point when the inflammatory response will protect us and not harm us.